A normal lymph node, we see capsule with germinal centers. These germinal centers have nice follicles with nice germinal centers and retained mantle zone and open sinuses and a paracortical region with some vasculature. This is all benign. Again, at higher power, a lymphoid follicle with a nice benign germinal center. Sometimes they can have tangible body macrophages, a retained mantle zone, small vessels, and open sinuses or subcapsular open sinus. I would like to go through some cases that were worrisome for neoplasia or malignancy based on suspicion on imaging, either CT or PET scan, or there's some morphologic suspicion, but after review or phenotyping and molecular studies, they turn out to be benign processes. And this has, as you understand or know very well, clinical consequences and implications. So the first case was 20-year-old with a history of seminoma. CT showed some enlarged lymph node, and PET scan showed positive lymph node in the axilla area. But on H&E, what we see here is lymphoid hyperplasia, variably sized germinal centers, ranging from small to medium. But focally, there are these much more enlarged follicles or germinal centers. Some have irregular borders, but there's this focal enlarged nodular lymphoid proliferation involving just like 2 or 3 of the germinal centers or follicles. But at higher power, they're composed predominantly of small lymphoid cells and a few centroblasts. We don't see LN8 cells or onion skinning or prominent immunoblastic proliferation. On CD20, again, these highlight these focally enlarged germinal centers, negative on CD3 and BCL2. CD10, there's some focal staining in the reactive germinal centers. And MIB1 is pi and polarized in the reactive germinal centers, and again, low to focally high or dispersed in these 2 enlarged germinal centers. And these range from about either 4 to 6, and some older textbooks talk about it can go up to 4 to 40 times the normal surrounding germinal centers. So this is what we call progressive transformation of germinal centers. They're benign. They're associated with follicular lymphoid hyperplasia. When you see this, sometimes you think of and raise, is this involved by focal follicular lymphoma or follicular lymphoma in situ localization, nodular lymphocyte predominant Hodgkin lymphoma. And as we mentioned, we did not see like angulated cleave cells or LNH or popcorn type cells at higher power. They're associated with what we call ALPS, or the autoimmune lymphoproliferative syndrome, associated with the FAST ligand gene mutations, or pediatric marginal zone lymphoma. They can cause false positivity on PET scan. They can sometimes occur in the rectum or skin and nodal or extranodal sites. Here's another case, a 62-year-old female with a right axillary lymph node. And she had a history of follicular lymphoma, and scans and biopsies were done to rule out lymphoma. So here's a PET positive lymph node in the axilla. But what we see here are a lymph node that's somewhat effaced, but the germinal centers are quite small, tiny, almost regress. There's some adipose tissue here, but they're somewhat irregular and all small or too tiny in size. Here again, very small germinal centers. So it was CD20, BCL2 negative, and high MIB1 polarized, high MIB1 proliferation, which are all characteristic of a benign process. This was her diagnostic or prior lymph node that had that cricoid effect and angulated cells, but these are all polyclonal by kappa lambda, HHV8 EBR negative. Flow cytometry did not show clonal B cells. Fish showed 14, 18, and 1% of interphase cells. So this is a reactive process in a patient with history of follicular lymphoma. Another case, a 19-year-old male with bilateral neck lymph nodes that were PET positive. And again, we see reactive hyperplasia with retained mantle zones, variably sized germinal centers, BCL2 negative, MIB1 high, polarized. When I mean polarized, there's like a higher proliferation in what we call, I guess, a dark zone versus slightly lower in the lighter zone, and variably sized germinal centers. This case turned out to be EBV, or by EBR1 in situ, which shows this sort of black-blue, it's an RNA probe, it's a nuclear localization. So this turned out to be florid follicular hyperplasia with focal Epstein-Barr virus positivity, and in this setting we suggest a serum monospot test to rule out infectious mononucleosis, and all the other studies, kappa lambda, were also polyclonal. So this is a benign EBV-associated reactive process. Next case is a 6-year-old male with bilateral neck lymphadenopathy and rule-out lymphoma. So here's lymph nodes. And section showed again these lymphoid proliferation, but again very small, regressed, tiny germinal centers with retained mantle zones. Here again, very tiny regressed germinal centers. Some vessels either penetrating or extending from the germinal center, forming what we call the lollipop sign. Sometimes they can have some lymphocytes that encircle the germinal center, forming what we call the onion skinning feature. Again, more pronounced onion skinning. You can have vascular proliferation between the germinal centers. So this was Castleman disease, and you have the plasma cell variant and hyaline vascular type and multicentric variants, and they can be associated with EBV and HHV8. And sometimes they can have light chain restriction in their germinal centers, but the single disease sites are benign. The multicentric Castleman type is you can be more symptomatic, involves IL-6 with IL-6 therapies. This is another case showing some sort of lymphoid proliferation with focal open sinuses. This case, the fellow said it was a benign hyperplasia. However, here's the BCL2, and what we notice is there's a positive BCL2 in these follicles, so that's does not support reactive process. Usually reactive lymphoid hyperplasia shows BCL2 negativity, and others show very intense BCL2 localization despite open sinuses. So here again, intense BCL2 localization despite open sinuses. So this is a 57-year-old male with an ileocecal valve mass that was biopsied and then resected. And so the patient had follicular lymphoma, and these prior nodes were the intestinal lymph nodes that fellow thought were benign, but actually had follicular lymphoma with in situ localization by follicular lymphoma. So here's again the intestine showing follicular lymphoma with back-to-back nodules without mantle zones. And these cells are positive on CD20, BCL2, CD10, BCL6. And you can see MIB1 is low and dispersed compared to reactive germinal centers on the side, which had a more polarized, higher reactivity. This is a case where a 73-year-old female, history of mediastinal adenopathy, and the issue is rule out lymphoma versus carcinoma, and frozen section is performed. And so these are scary cases. Surgeon is, waiting behind your back and asking if this is lymphoma, large cell lymphoma, or some sort of carcinoma. If it's lymphoma, they'll stop. If it's carcinoma, they may continue. So what do you think? Cells are blue, somewhat medium to large in size. Some focally have either anaplastic or molding type features. Some are necrotic, some crush artifact, but large blue cells. But on immunohistochemistry, they're CAM 5.2, AE1 positive, synapto and chromogranin showing neuroendocrine differentiation. So this is a neuroendocrine carcinoma, not lymphoma. So small cell carcinoma treated, but ultimately died. Here's another case or situation where it's a 58-year-old male with a history of Merkel cell carcinoma and CLL, now with extensive retroperitoneal adenopathy. And question is, on biopsy, is this carcinoma? Is this transformation of the patient's CLL to DLBCL? So here again, biopsy with these blue cell proliferation, somewhat like ground glass appearance or fine chromatin. Again, by IHC, positive on CAM 5.2, focal weak to negative on AE1. But chromogranin, synaptophysin, BCL2 very positive and negative for lymphoid markers. So this supported, again, carcinoma with neuroendocrine differentiation and not lymphoma. Immunoblastic proliferations can also look like lymphoma. Here's a case where it's effaced at higher power, somewhat effaced, but a lot of apoptosis, karyorrhexis. You have this sort of crescentic histiocytes. So this is an example of Kikuchi, necrotizing lymphadenitis, or Kikuchi-Fujimoto disease. They can mimic T-cell or B-cell lymphoma, large B-cell lymphoma, but they have these crescentic histiocytes that are CD123 positive. They can be 123 positive. So the differential diagnosis, is this diffuse large cell lymphoma, anaplastic large cell lymphoma, or necrotizing lymphadenitis. In this case, turned out to be necrotizing lymphadenitis. So non-neoplastic mimickers of lymphoma, It's based on, either clinical suspicion or morphologic suspicion. We saw the role of phenotyping, genetics, and of course, you well know the consequences or implications of misdiagnosing benign process versus neoplastic process. So pitfalls, critical to get clinical case information, the history, to avoid misinterpretation, using ancillary tools, and most importantly, consult colleagues, consult in consensus conferences, and discuss with colleagues. And here are my references. Thank you so much.